is also a part of your testing measures. You're going to establish your infield or have a clinical impression of your infield when you perform what task? Passive range of motion. Good job. So when you perform passive range of motion, you are gathering information about the infield. Again, this is foundational for evaluation, differential diagnosis, and prognosis. This is entry-level content. So our objectives are students will know the meaning and purpose of infields and how they apply to the foundations for evaluation, differential diagnosis, and prognosis. Students will be able to demonstrate, assess, interpret, verbalize, and document infield findings accurately. What is the definition and purpose of infield? So the definition of infield is the sensation, resistance, or feeling which the therapist detects when the joint is at the end of its available passive range of motion. Notice, at the end of its available passive range of motion. If you are assessing active range of motion and you have the goniometer aligned and you take the goniometer measurement and you give me an infield, is that possible? What do you say, Liz? Liz is shaking her head no. But it does happen, Liz, during the practical. During the practical exam, students will be tasked with quantifying range of motion. So if you're tasked with quantifying range of motion, and that is your task, what is that asking you to do? That's asking you to take a goniometric measurement, because you're quantifying the active range of motion. So if you quantify the active range of motion, you're not actually assessing the passive range of motion and giving an infield. You're giving an accurate reading of the range of motion that the person achieved for whatever joint. I go to say this, if you're tasked or when you're tasked with quantifying range of motion, don't give Dr. McClure and I an infield. So some students do that. They will quantify active range of motion and they say, oh, this person had a normal firm infield. And I'm like, did you assess passive range of motion or did you assess active range of motion? It happens, okay? So just know that you'll be assessing the infield when you perform the task of passive range of motion at whatever indicated joint that you're gonna be tasked with performing passive range of motion, all right? So the purpose of passive range of motion and infield is to provide you with an appropriate assessment of infield, which can help the therapist with clinical decision making. It can help you to assess whatever type of pathology may be present. It can help you assist with identifying limiting structures, and then you can choose an effective treatment. It also helps you to determine a prognosis for the condition, and it also helps you to learn the severity or stage of the problem. So infield, assessing the infield in conjunction with passive range of motion has its place in examination, differential diagnosis, and prognosis. Remember earlier we talked about knowing the types of normal infields. So these are the entry-level infields that you need to know. These are the infields that you can be asked about on the National Physical Therapy exam, okay? These are the infields that you need to be feeling for and assessing when you work with your patient. So we have normal infields. The normal infields are soft, firm, and hard. Again, these are entry-level infields. There are many, many more types of descriptors of infields out there. But for the purpose of you all becoming entry-level physical therapists, you all need to know these and how to interpret these. So the soft infield is soft tissue approximation. Examples of soft tissue approximation is knee flexion and elbow flexion. So when we talk about knee flexion, now you need to also know the structures that are coming in contact with each other because you may see that. So with knee flexion, which soft tissue structures are contacting each other? So we got the gastrocnemius muscles coming in contact with the hamstring muscle group, right? So that causes for a normal soft infield. That's what you expect to see. That's what you expect, okay? Elbow flexion, which muscles are coming in contact with each other? So we got the biceps brachii, and we got the superficial forearm flexors. So what do we got? Soft infield. So what are those muscles? We got flexor carpi radialis, right? We got flexor carpi ulnaris, right? We got palmaris longus, right? What else we got? Pronator teres, right? So you need to know those. So you need to be able to verbalize. You notice I challenge you all. That's going back to anatomy. I'm going to challenge you all. I'm going to say, oh, what structures are coming in contact with each other if it's a normal soft infield? So now you got to go back and review your anatomy, right? All right. Now, firm infield. So you have several characteristics of a firm infield, and these are described in Norkin and White for each joint. So y'all got catch up what to do. If you don't have a strong command of this, you all need to go back and practice with each other for every single joint, following Norkin and White, mobilization hand, stabilization hand, looking at what the normal infield should be, okay? So for a firm infield, you have a muscular stretch, capsular stretch, and ligamentous stretch. For a normal infield, for examples of a firm infield, you have hip flexion with knee extension. So now, if you have a firm muscular stretch, a firm infield with hip flexion and knee extension, you should be able to tell me which muscle or muscle tendon unit is creating the tension. You should be able to tell me that in the lab practical. Right, Jacayla? So now, Jacayla say, Okay. So now, Jacayla, which muscle is it that's most likely causing the tension with the hip flexion with the knee extension? There you go. That's it. That's what I want to hear. Because that's going to prevent the hip from going into more flexion. All right? Good job. You got a capsular stretch. So a capsular stretch, a good example would be MCP extension. So MCP extension, metacarpophalangeal joint extension, is going to be a capsular stretch. But now I'm going to come back and say, according to Norkin and White, which part of the capsule? So I'm going through this because I'm telling you all how y'all need to be studying. Don't just study broad, you got to study specific. So which part of the joint capsule is going to be stretched? Normally with MCP joint extension.
Like location, like palmar side, or is it like an actual?
So it's going to be an actual area of the joint capsule. An actual area of the joint capsule. Which portion of the joint capsule is going to be stretched with MCP joint extension? So if you put yourself in an anatomical position and do passive range of motion of MCP joint extension. What does it say, Andrew?
Palmar joint capsule.
Palmar joint capsule. Now, what's another word that can be used besides palmar joint capsule? Anterior joint capsule. So now, when you think about these, you got to place yourself in an anatomical position. This is all in reference to the anatomical position. So now I'm standing in an anatomical position, right? Okay. Come here, Tia. Take my MCP joint, any one of them, and move it passively into extension. Okay. So she chose my middle finger to move it passively in extension, right? So now go ahead and do that. All right, as far as she can go, right? See if you can go a little bit further. All right, good. There you go. Now she has a capsular stretch, and the anterior portion of the joint capsule is stretched because she's moved my MCP joint into extension. Now what's going on with the posterior joint capsule? Huh? Slack. There's nothing going. It's in slack because she's taking my proximal phalanx into extension. Okay. Now what if she takes it into flexion? Take that MCP joint into flexion. Take it. Now where is my joint capsule tight stretch? Our capsule stretch is going to be. There we go. Posterior dorsal aspect. Okay. So you're going to have to study in depth. Again, go to your Norkin and Wright. Again, this is entry-level content. This is National Physical Therapy Exam content. This is content that you have to have a strong command of. You have to strongly command this content. All right. Ligamentous stretch. Forearm supination. All right. So forearm supination is an example. So what's stretching? It's a ligamentous stretch. So you got to be able to verbally tell me this during the practical. So you just can't tell me ligamentous stretch. I want to know what structure, what ligament. I want to know which portion of the capsule. I want to know what muscle. So you're not just going to be able to tell me it's a normal, firm, muscular stretch. You're going to have to tell me the structure as well. All right. So for forearm supination, what do we have between connecting and conjoining our radius and our ulna? So yeah, you got muscles, but it didn't say muscular stretch. It says ligamentous stretch. So there we go. The interosseous membrane. Somebody's looking it up.
Yeah.
Good job, Tia. Research it if you don't know. Become independent researchers. So if you don't know something, look it up. That's how you gain knowledge. If you forget something, go back and review it. That's how you retain knowledge. What did I just say? What in the world did I just say?
That's how you take
Look it up if you don't know it. That's how you gain knowledge. Then what I say? Look it up and review it if you forget it. That's how you retain over time. All right? You think us as physical therapists know all of the anatomy off the back of our hands? Off the back of our hand? Man, it takes constant review to retain it. All right? It takes independent research to gain knowledge. All right? So, moving on. A normal hard end field would be bone contacting bone. So we expect this with elbow extension, right? But what is contacting wet? That's what you're gonna have to tell me as well. Okay? So we got Trey. What do you say, Trey? With a normal hard end field with elbow extension, what is contacting wet? So you got your lab practical, you got assessed passive range of motion of elbow flexion. You go through the spiel and you say, oh, Dr. Carter, the end field is a normal hard end field. They'll say, oh, okay, Trey, well, what hard structures are contacting each other? What osseous structures are coming in contact with each other? And what are you gonna say? Okay, there you go. So you got the olecranon process of what? Of the humerus, contacting what? Okay, contacting ulna. Good. That's what you're gonna have to verbalize. So I'm telling y'all in advance, I'm going through this. So I set high expectations, but I don't set the high expectations without going back through covering the content, teaching the content. Remember I told you all I wasn't gonna leave you in limbo? I'm not gonna leave you in limbo hanging. So what needed to have occurred previously was an in-depth teaching of this right here, stressing and emphasizing that you need to know this. That way you're not playing catch up. all right? Right now, we're playing catch up. But it's important. Now, to know the abnormal, you have to know the normal. So now we have our types of abnormal infields. So we have a soft tissue approximation at a joint where soft tissue approximation should not be occurring, all right? So an example of when we can have a soft tissue approximation is when we have soft tissue edema. So you have swelling going on somewhere, significant swelling, in an area that's gonna create a soft tissue infield where a soft tissue infield should not occur, okay? Synovitis. So what is synovitis? What in the world is synovitis?
Inflammation of the synovial joint.
So inflammation of the synovial membrane, okay? Inflammation of the synovial membrane. And if the synovial membrane is inflamed, then one could present with a soft infield. So we have an example of an abnormal soft infield, that is, okay? Soft tissue edema, again, I treat patients with lymphedema and they are extremely swollen, right? So if I treat someone with lymphedema of the upper extremities and I happen to go through wrist flexion and they're swollen in the hands and they're swollen in the distal forearm, it could be a potential that they could likely present with an abnormal soft tissue infield because they're not supposed to be soft. So I'm just giving y'all examples, okay? That's not supposed to be a soft infield with wrist flexion, but it could be if I got a patient with lymphedema, all right? Then we have our abnormal firm, where we have abnormal muscular stretch, abnormal capsular stretch, and abnormal ligamentous stretch. So when will we have an abnormal muscular stretch is when we likely have increased muscle tone, okay? Hypertonicity of muscle, all right? So what does that look like though? What does it look like? That's what we have to know. Okay, Tia, come up here and lie down for me.
Okay.
All right. So go ahead and place your knees flat on the mat for me. Place your feet flat on the mat for me, on the plant. So now, okay, I'm just gonna pick the shoulder joint, right? So I do passive range of motion. I come here like so. Come here like so. And I take her into flexion. And this is as far as she can go. All right? This is as far as she can go. Now, if this is as far as she can go, I'm establishing a sensation or feel for what could be causing this. All right? Now, I'm gonna say, all right, I'm gonna assess her component motion. So if I assess her component motion, I'm gonna be teaching y'all that. So I assess her component motion. So if I get her here, put her in a loose pack position, she's in a loose pack position, and I assess her posterior glide. Normally I have a towel roll under here, slightly abducted, about 55 degrees, abduction per se, according to textbook. Put a towel roll under here, and I'm looking at her posterior glide. That feels good. I come back, try to keep her right. Well, I have a towel roll right here, so come back, stabilize right here, assess her anterior glide. So I'm assessing different glides. I come right here, assess her inferior glide. I say, oh man, her component motions feel good. I don't feel any restrictions. Her component motions are smooth. There's no aberrant motion, no jerking. So I wouldn't consider it capsular per se. Is her component motions are plane free. So this is how you tiny information. So now her infield, I'm getting a feel for her infield. It has to be musculature. All right, could be ligamentous, but I'm gonna go with musculature. So now, what muscles could limit shoulder flexion? Okay, posterior delt. Why do you say posterior deltoid?
Because it's the antagonist to the anterior delt.
Is an antagonist. So now you have to think about your antagonist muscle groups to that motion. There we go, Tia. Now Tia's thinking now. Now we're applying our clinical reasoning. So when I'm taking time to go through this, if I'm taking time to go through this, what does that mean?
See it again.
You're gonna see it again. You need to know it. You're gonna see it again in the near future, and then you can likely see it on your National Physical Therapy exam. So now, pectoralis major. How about that? What does it do?
Horizontal beam.
So it's a horizontal adductor, but would it limit flexion? What does it have to do when a person go into shoulder flexion? Does it have to elongate with flexion and abduction? Yeah, it has to elongate. So that could be a muscle that could be taut. I have to assess it. What's another one that we've already talked about? That if it is taut and has a significant amount of tension, it can limit shoulder latissimus dorsi muscle, which is often overlooked. Okay? Now, if you go and look at Norkin and White, and you pull up Norkin and White, look and see what it tells you that could be contribute to abnormal, what should be a normal infield, but then you know what could be abnormal, okay? So we don't make it to the end range, and now we can go off patient reports. Patient report is significant. So if I get her here, right, and this is as far as we can go, now this is a teachable moment. If this is as far as she can go with shoulder flexion, now her report is going to be significant as well. Why will her report be significant? Say again, Andrew.
Where she has tightness. Where
So
she feels tightness.
there you, if the patient says, I don't feel any pain, I just feel a tightness sensation, a pulling sensation, then that's going to direct me to it being more musculature as the abnormal infield. But what if the patient say, oh, I don't feel like I'm tight, it just feels like it's painful. I'm having a lot of pain. And if that's as far as she can go due to pain, then entry level, what would we classify that abnormal infield as? Empty. So unable to reach an end range secondary to pain, and that's his entry level, then it would be considered an empty infield. All right? So empty can be due to acute joint inflammation, bursitis, some type of abscess, fracture, or psychogenic disorder. All right? Thank you, Tia. All right? So we have capsular stretch and ligamentous stretch. So you have muscular, capsular, or ligamentous shortening contribute to an abnormal infield. So now, how would I classify when I assess the component motion? I'm going to teach you all this. You all may not know this yet. So when you're assessing component motion, Dr. McClure and I are going to be encouraging you to assess and give us the quality of that motion and also the infield of what you feel when you assess the component motion or accessory motion. So when you assess the component motion, we're assessing that capsular infield, right? So if you feel some type of tightness or you can't get to a certain grade, then most likely it could be an infield, an abnormal infield due to a capsular stretch, okay, or capsular tautness. It's just not allowing that the head or whatever, the head of the femur, the head of the humerus, it could be not allowing it to move in a certain direction as it should. And then with hard, abnormal hard infield, we have bone contacting bone when it should not be. So there would be a case of chondromalacia. Where in the world is chondromalacia? What in the world is that?
That is, it's a confliction of the hyaline cartilage coating of the articular surfaces of the bone.
Okay, all right. So chondromalacia is, repeat that again, Ted, that was good, that was good.
It says it's an affliction of the hyaline cartilage coating of the articular surfaces of the bone.
Okay, good. Everybody hear that? Now, specifically, you will hear this term thrown about more so at the patella. You say patella chondromalacia. That means the cartilage that's covering the patella is worn or torn or depleted, completely deteriorated. And now you have a bone-on-bone of the femur, patellofemoral articulation, and they typically refer to that as patella chondromalacia. What about OA, osteoarthritis? If somebody has osteoarthritis, they can present with abnormal hard infield. If someone has MO, myositis ossificans, have you ever heard of that? So a person has injury to the muscle, some type of bruise to the muscle, where they don't receive interventions that they should, and they let the condition like become chronic without appropriate intervention. And what can happen is you can get calcium deposits within the muscle, and the muscle become calcified, fibrotic, and also shortened. That's the case where you can get also hard infield, and then also loose bodies within the joint. Okay, can present with an abnormal infield. Those are the references. Hallmark reference, Norkin and White. Measurement of joint motion, a guide to goniometry. Dutton, guide to physical therapy. What questions do you have? All right, so that concludes the presentation on infields. So now we know what we got to do.